Welcome, everyone. I'm Dick Deming. I'm Medical Director of MercyOne Cancer Center, and I'm the founder of Above and Beyond Cancer. Welcome to our weekly cancer education series. It's brought to you in part by a grant from the Iowa Oncology Society. And this evening, we're going to be talking about physical therapy. And I have with us tonight a friend and a colleague, Esmie Holderman. Welcome, Esmie.
Hello, good evening.
Esmie is a physical therapist, and she's with MercyOne. Her main gig is at the MercyOne Riverside Rehabilitation Center, but she also provides physical therapy services at the MercyOne Richard Deming Cancer Center.
Yes.
And she's a Go Big Red University of Nebraska football player. No, swimmer. Competitive swimmer, D1 scholarship.
Many years ago,
yes. So, Esmie, where are you from? Where'd you grow up?
I'm from Southern California, and then I did go to Nebraska.
So you were recruited there primarily for swimming?
For swimming.
Yep. And so did you know you wanted to do physical therapy?
Yep. So I graduated with a biology degree, and then I went back home to Southern California and became a physical therapist at the University of Southern California.
Oh, so your undergrad was at the University of Nebraska, but then you actually got the physical therapy at USC.
Correct.
So after you've already have a 4-year Bachelor of Science degree, how many extra years before you get your Doctor of Physical Therapy?
3.
3. And that was done at UCLA. No, I'm sorry. USC. Oh, I'm sorry. That's like confusing the jackrabbits with the coyotes.
Kind of.
Yeah. So, sorry. So you were a Trojan.
What?
Yes. And what medical center did you use for your clinical education?
Well, we got to go everywhere.
Everywhere, like?
I went to one in Wyoming. I went to one in Tennessee. I went to one in California, San Francisco, San Diego.
Okay.
So, yeah.
Wow. It's like, why go to USC if you're going to get shipped off to Wyoming?
I know.
Did you have to find your own clinical experiences?
You got to go, and they helped you coordinate them.
So when you're doing your clinical education in physical therapy, do you rotate through inpatient settings, outpatient settings, stroke rehab?
Yes. All the above.
All the above.
Kids.
How about oncology?
No.
That was not a rotation.
Never had that privilege.
So then you came back to the Midwest.
I did. And landed in Iowa.
In Iowa. Yeah.
Yep.
And how long have you been a physical therapist at Mercy?
14 years.
14 years. And during the course of that time, what would you say has been the biggest change in the practice of physical therapy overall and during your career?
Well, I know, personally, I started out with pool therapy. And I also did clinic therapy. But then transferring from that, then I went strictly to the clinic. And then I started seeing more patients with neurological conditions. And now here recently, I've added the oncology part of it. So I guess it's more the people I treat versus...
One thing that I've observed, but it just could be in Des Moines, but just lots more physical therapy places that are opening up everywhere, like independent or nationwide chains that are chains of physical therapists that are opening smaller shops around the metro. So I know that over the course of your career, because we've also been triathlete friends, that as you said, you got interested in neurological physical therapy rehabilitation, and I think you went through a training program. I'm not sure if it was specifically brain tumors or if it's neurologic.
So I'm board certified in the neurological clinical practice of physical therapy. And then I also did a fellowship on multiple sclerosis in Canada.
Okay.
Before COVID. And then,
And you're currently working on...
I see a lot of people who have multiple sclerosis or who have spinal cord injuries, etc.
And currently you're working on a specialty certification in oncology.
Correct. Yes.
So what would you say is the main focus of why is there a special certification in oncology, and what would you say are the special concerns or needs for physical therapy in oncology?
Well, I think, well, first of all, a lot of the training is a lot of the background because, like we discussed earlier, you don't get a lot of that in school, and so you don't learn about the chemotherapy drugs or a lot about radiation.
Mm-hmm.
I feel like you learn about surgeries in general in school. But then you add things like lymph nodes and lymphedema on top of that with cancer treatments. So a lot of the continuing education is on learning about the medicine behind it, and then how then physical therapy can affect and treat those things that people might experience after the cancer itself, after surgery, after radiation, or after chemotherapy.
Right. So a lot of what we might ask you to take care of are sequelae or side effects or consequences of the cancer treatment,
right?
Rather than consequences of the cancer itself.
Correct. Yes. Yeah. Yes. And people can have any range of symptoms, whether it be fatigue or the surgery itself left them with limitations, say in range of motion, or maybe they experience neuropathy, pain, lymphedema, although I don't specialize in lymphedema, but there are people who do.
So it could be sensory deficits, neuropathy, could be weakness. Yep. It could be radiation fibrosis and stiffness that limits range of motion or function.
Balance issues, falling.
Okay.
I'd even kind of with the fatigue, if someone's having challenges with going back to work or something to that effect of having enough energy to get through their work day, for example, or whatever else their day might entail.
Yeah. So there's this phrase, and correct me if you use a different phrase, but deconditioning. Let's say somebody has gone through a chemotherapy followed by a major surgery, followed by some radiation, and they come off the end of that conveyor belt just exhausted and weak. How does a physical therapist approach that just general weakness, loss of strength and stamina?
Well, I think it's very important to work with the patient to prioritize their goals, to know what kind of activity they need to get back to or desire to participate in again. So whether that's work or family or hobbies that they enjoy, find out what motivates them. And then basically it's a matter of triaging what's, the most biggest deficit as far as strength goes. And then it's going to take time though with the fatigue and the deconditioning.
So explain what would be the difference in that situation where we're not talking about a particular body part that was injured,
right?
But that this generalized loss of strength and stamina. What is the mindset difference that of you approaching that versus a personal trainer approaching that patient?
So taking them through, sometimes it might be important to take them through like a submaximal test to get a baseline as far as where they are. And then using some of that information and data, such as like their heart rate or things like that, to help guide the person, because there is homework when you come to physical therapy, which sometimes is not.
Which is an hour a week with you doesn't do it?
Yeah. So that might be true. And so, but giving the person guidance as far as how that homework should look so that they can continue to progress in a way that is successful, so that there's not the boom and bust of like trying too much too fast. And so that doesn't necessarily lead to success. So trying to find a nice graded approach.
A little bit more of structure with a
As well
focus
as
on-
incorporating things like flexibility or the specific strength training that they might need.
Okay. So you used a phrase, cancer rehabilitation. Yeah. Let's bring up that slide you have and talk to us a little bit about, I mean, I think people know if somebody has a stroke, there's rehabilitation.
Right. And I think that it can be at any point along their journey, whether it's as soon as they're diagnosed, if that's what the person is wanting or willing to do, or it could be 10 years down the line. So that's one of the key things about it. And then it's, again, about increasing their personal ability level where it should be tailored to their activity. And it can be any point in their journey of active cancer treatment, survivorship, etc. Because there's statistics out there where I think it's like 90% of patients experience side effects or have residuals from cancer treatment, but only this small percentage actually seeks treatment on that.
And this definition really fits in with the above and beyond cancer concept of optimal living. You know, what's the best you can possibly be given what your journey has been.
Right. And I'm very aware and conscious of there's a lot of emotions that go into having cancer and going through that cancer treatment and the cancer journey. So I don't think that everybody is going to sign up for physical therapy as soon as they're diagnosed. And that's not for everyone. It's when the person's ready to engage in that. And
so we talked about one general category of just deconditioning, a loss of strength and stamina. What are some of the more specific issues where we would bring you onto the team as a physical therapist for a cancer patient?
Yeah. So especially if there's a surgery and especially if there's a radiation involved, I find that a lot of people have the fibrosis, the stiffness, the scar tissue that you described, which can result in decreased range of motion. So the common example that I can think of is a breast cancer survivor who might have a surgery, who might have a radiation on top of that, who might have limited shoulder range of motion, which might affect them getting their clothes on and off, or their seatbelt on and off, or reaching for their kid in the back seat, or something to that effect, where that would be their goal and motivation, and what we could do to help increase them with some manual treatments or stretching exercises, strengthening exercises. Sometimes numbness and tingling is also an issue that comes along with that.
Okay. So related to specific surgery and radiation, other examples of cancer patients that you've worked with and specific issues that they might have experienced that you can help with.
So another one, and you're going to have to help me.
Okay.
It's called aromatase inhibitor.
Aromatase inhibitors, yes.
Arthralgia, so joint pain.
Yep. And so for those who don't know,
Yes.
aromatase inhibitor is one of the anti-estrogens. So a woman that is past menopause that has an estrogen receptor positive breast cancer would often be placed on an aromatase inhibitor pill that they might be required to take for 5 to 10 years.
Right.
And one of the side effects is
joint pain.
Myalgias and arthralgias.
Yes.
So myalgia is muscle pain and arthralgia is joint pain.
And so those are things that physical therapy is not going to cure that, but can help the person work through some of those issues that they might be having.
Okay. How about patients that have been treated with chemotherapy and radiation for head and neck cancer?
I would rely on my speech therapist friends.
Okay.
And some occupational therapy friends.
Yeah, and they're not just friends, they're colleagues.
They are.
At your rehab center,
correct.
There's often a triad of therapists at a rehab center: physical therapy, occupational therapy, and speech therapy.
Yes.
And so one of the side effects can be really neck stiffness from the radiation fibrosis.
Yes.
So
and that can be treated with physical therapy, specifically manual-based treatments would be most ideal for that situation.
And then kind of an obvious example would be people who have sarcomas of bone or muscles of the limbs, for example, where they get a large tumor removed that also removes some muscles or crosses a joint or has to have that. So they end up with some of the orthopedic type of limitations, functional limitations that people would often think of as physical therapy.
Right. And that's a matter of optimizing their function based on what they have had removed, if there's been muscles removed, how much has been removed, etc. So that's working to optimize with what they have.
So I imagine you don't get through a physical therapy training program without understanding that people who have hip replacements and knee replacements and shoulder replacements, that those are a common patient that you learn very easily how to deal with. What's would you say is different maybe in communication or the whole psychosocial of learning how to work with patients that may have living with incurable cancer? I mean, I imagine that, somebody just had their hip done and it's like, okay, I want to get back to it. And it's like, rah, and let's go and setting goals. And, but someone who's had a major cancer surgery and might have other cancer and.
Right. But that's where it's really important to talk to the person to find out where they've been, what they've been through, but then also what they would like to get out of it and what benefits they would like to have. Specifically, like finding out how their day-to-day life goes, how their home situation is. Do they have to climb 3 flights of stairs to go to bed every night? That's can be a challenge. Or if they're on a 1-level handicap accessible house, like that would be a totally different situation. How much care support they have, that's another big one. If they're living by themselves and have to do all their own meal prep and have to get themselves to the grocery store and back, so that I have an idea of what they do in their day-to-day and what they would like to be able to do.
And how important is it for you to know what's the status of their cancer, where they may still have cancer, what form of ongoing treatment they're receiving?
And that's where it's important to get that from the medical team to have that. It's also nice to get it from the patient too, so that to get their understanding of how much they understand what's going on and how they feel their treatment affects them gives me a good idea of how therapy might go and how it might look and how it will affect our time together and their ability to do exercise and be active.
Yeah. So when somebody gets sent to you by orthopedists because they just had a hip replacement, there's probably fairly standard sorts of protocols for how to advance. Would you say that when you meet one of our patients that there's more conversation that happens at the beginning before you get started?
Yes.
There is not just this, I know this is what I'm going to be doing.
Yes. I think it's also helpful so that they can tell you their story and their journey, because everybody has their own story to tell and how they experienced what they went through. But then, yes, you have their medical background besides their cancer journey as well, which is nice to understand and get to know the person and their whole story.
And obviously, that's one of the reasons we brought physical therapy into the cancer center in an integrated fashion, so that you become part of the team and are aware of, what's the status of the cancer, what's the treatments they've had, the surgery they've had, the radiation they've had, and helps give a better understanding of the entire person and their family.
Yes. Most of them do come with care partners.
Mm-hmm. Do they come back to the room with you?
Sometimes.
Mm-hmm.
Sometimes not.
Do you have a preference?
No.
No.
Sometimes people like time apart.
Uh-huh.
Sometimes people like to stay together. So
usually, correct me if I'm wrong, but usually the patient remains fully clothed
Right.
while you.
For the most part,
Mhm.
unless they have some specific area that might need to be revealed, but like a tank top or something might be appropriate for a female to see their shoulder, for example.
So what have you learned so far in your specific oncology certification?
The number of people that have neuropathy is huge.
As a consequence of their treatment,
Yes.
especially the chemotherapy, but radiation as well.
Yes. And in my experience, that's probably one of the biggest things that people come to me talking about. And one of the things that we can work with the patient on as far as so pain can be described as an uncomfortable sensation. So it doesn't necessarily have to be pain, but it's not a joyous, comfortable sensation, right? Having numbness and tingling. Sometimes numbness and tingling can be painful. But they'll come with pain because of the numbness. And that's where we can work with the patient on specific exercises as far as they're called neural mobilizations to help get the nerves moving more freely, more happy, more with less pain, less numbness and tingling in their everyday day-to-day activities.
Okay. We've talked about neuropathy. We've talked about general strength and conditioning. We've talked about individual body parts where there might be some restriction of function related to surgery or radiation therapy. Any other categories of issues that cancer patients have that you work on?
Well, I don't specifically, but we should talk about lymphedema because I
Okay.
do feel there are therapists who do specialize in lymphedema and lymphedema therapy to help manage that, to get it to a controlled level to the point where they could use a compression garment to help them keep it controlled and continue with their day-to-day activities.
And would you say that lymphedema requires a special extra certification?
Yeah.
Yeah. And sometimes it can be an occupational therapist.
Yes.
I think our lymphedema specialist at the Katzman Breast Center is actually an occupational therapist.
Correct.
Been credentialed. We talked about some of the changes that's happened in physical therapy. Another change that I have seen, and maybe I'm just more aware of it, but lots more gizmos, gadgets, and apparatuses, from cupping to dry needling to hammers and vibrating things. Can you maybe go through a discussion of the various types of apparatuses, what they're officially called,
Sure.
which of those need special training for you to do, and what do you do just in the course of regular treatment? Like instead of using the ball of your hand, you might use a
Right. Well, one would also be kinesio tape. So having all the people taped in the Olympics with various color tapes on them.
And does the particular color affect the function of the tape?
I'm sure the brand makers would like you to think so. But those can be used for edema to help with that. If you have muscles that are spasmed, it can help with that. It can help to relax muscles or encourage them to be more active. So if a joint, say, is unstable, that can be used to help provide more stability. So that would be the taping.
Okay.
The cupping, I cannot speak on that. Besides, it causes bruising. Have never done that in my
Okay.
life.
Have you had it done to you?
No, I
Okay.
have not
Okay.
had that privilege. I feel like I'm missing out.
I've not had it done, but
Oh, okay. There are specific tools. So, like you were talking about using the heel of your hand, they're usually metal tools. I've had patients describe them as like a turkey slicer, they think it looks like. So, that's a very technical term.
is that
But
for
they're
scraping?
well, they're used for a manual tool for like a soft tissue mobilization, and they can be helpful. There's massage balls. What else did you bring up?
Dry needle.
Oh, yes, dry needling. I am not trained in dry needling. You do have to be trained in dry needling. That's for these. I've never seen it done actually, but my father has had it done. They stick small needles in, provide electrical stimulation to it, and it's supposed to help with a specific muscle that might be in spasm, aggravated, inflamed, etc., causing pain.
Okay.
The blood flow restricted treatment is a type of treatment that is used in both the orthopedic setting, as well as I have heard of it in the neurological setting, like we were talking about before. I work with people who have multiple sclerosis. I know that's why we're not here, but it is used in both different settings where a blood pressure cuff, basically a device that looks just like a blood pressure cuff and acts like one, is placed on the limb and is pumped up to restrict the blood flow to the rest of the limb, and then the person is taken through exercise to help increase the strength, to help facilitate, I should say, increasing the strength in that limb, and it can be very helpful. One of the situations that it's used for in orthopedics is like if someone is non-weight bearing, meaning they can't bear weight because they had a surgery or a fracture, then they do that, and it can really help the person make gains early on while not being able to bear weight.
Gotcha. So they don't get as much atrophy of the muscle.
And kind of, get that.
Okay.
Be more ready once they can bear weight. Like if you think of like an athlete and getting back to a high level, they can participate in that strengthening.
And what about like ultrasound or infrared or heat or ice or?
Yeah. I personally don't use a lot of those things in my practice, but they can be used. Ultrasound is used. Infrared. Okay. Don't have a lot of experience with that either.
So you have a few slides. There are some things that we have not covered, because I do want to transition from specifically physical therapy to talking about exercise as medicine.
Oh, yeah, for
But
sure.
before we transition.
Well, I will also say that sometimes too, people can experience dizziness. So in addition to their balance, which dizziness is a very interesting symptom that people have a hard time expressing sometimes. So they might say that they're off balance, or they feel unsteady, or they kind of feel like they're on a boat, or they have a difficulty walking a straight line. And so that might be related to the neuropathy, but that's also something. I also, I think a lot of times people think that physical therapy, they're just going to come like walk on a treadmill, walk on a bike, be given stretches or exercises, which, that is kind of what it is. But I also think that for some people, like it's a lot of exercise to go to the grocery store and walk through the grocery store and then come back. So I think having the physical therapist who can understand that and be mindful of that in the exercise prescription and what we give them to do can be helpful in their success, because it's important that we meet the person where they are for their greatest success.
So you mentioned dizziness.
Yes.
And I didn't know if you were going to go into the vestibular issue that happens when your little crystals kind of get stuck. And
Right.
is that also a special certification to be able to do that vestibular
Yes,
moves?
the
What's the proper term
repositioning.
for that?
The canalith repositioning technique. So
Say that again.
the canalith reposition.
Canalith
Yeah,
reposition.
in your ear. So yes, there is specific training you can get for, it's called BPPV, vertigo, where the room is spinning, specifically like rolling over in bed or getting up, where they test to see what ear is involved, because there are crystals in your ear. They can come dislodged. They'll make you feel like you're literally spinning, specifically when it's typically when the person's in bed rolling over. And then, yes, they can be taken through a procedure to put the crystals back in place, basically.
Okay.
And then, where did you say you wanted to talk about? Because I kind of wanted to talk about Above and Beyond, and how I think that Above and Beyond is a nice gateway for graduation after physical therapy. Because if someone comes for whatever reason, fatigue, deconditioning, neuropathy, or decreased range of motion, that we work with them, we get to the point where they're on their own. I think Above and Beyond is like the perfect next step, basically, to then find what's going to work for them, what time of day, where it is, what they enjoy, for then that lifelong exercise that they can participate, enjoy, and find other people who have that common interest.
Right. Because Above and Beyond Cancer has about 14 different types of activity programs that cancer patients, cancer survivors, their families can participate in. Everything from water aerobics, yoga, meditation, Tai Chi, pole walking, hiking, indoor cycling, outdoor cycling, weightlifting, calisthenics.
It's an amazing resource.
Yeah. And
it
so
really is.
Having an ability to transition from a one-on-one with a physical therapist to then participating in a group activity where you not only get the activity, but you might get it out in nature and with the fellowship all coming together.
Yes. Again, I know this isn't about multiple sclerosis, but I did a day program with multiple sclerosis with nursing and therapy. And afterwards, we asked the participants, what they, got out of it and what they loved. And their biggest thing that they all, I swear to God, it's like they did it all together, but their camaraderie was their number one thing that they felt like they got out of the whole program. And I think that's exactly what people experience at Above and Beyond Cancer. Is the person can facilitate the exercise group, but it's the participants that are there present that are what really make it such a impactful activity.
I mean, in this day and age, you and I can be in our living room and turn on the TV and bring on a YouTube video that would walk us through anything, but we're just doing it by ourselves. And the instructor may be fabulous, world famous instructor, but we're just doing it ourselves. And you're right. What Above and Beyond does is not only have that physical activity, but you're doing it with others, and not just with others who have had a common path with you.
And then I do find that the exercise helps bring, I guess, more of a positive environment where they have people that maybe they can talk about what they're dealing with, but the focus is not on those things. It's more on their path forward of what they're going through.
Well, let's transition a little bit more to talk about exercise as medicine, because that's really part of the Above and Beyond experience. So we know from studies that individuals who engage in vigorous physical activity while going through cancer treatment will have fewer side effects and better outcomes. And we know that people who live a lifestyle of eating healthy, maintaining a normal body weight, and exercising will have fewer cancer, fewer diagnoses of cancer. So it reduces the risk of cancer by exercising. It improves the outcome while you're going through cancer treatment, and obviously also improves quality of life. Motion is lotion. Talk a little bit more about what you mean as exercise as medicine.
Well, the American College of Sports Medicine also has a movement of exercise as medicine. Again, it doesn't have to be going, to a bike class or going on a miles and miles walk. For some people, that might be making sure their house is vacuumed, right? That can be an exercise for some people. They want it to be a somewhat rigorous activity, but if the person is not quite at that level, it might be something like vacuuming your house. But they're wanting some sort of aerobic activity is the goal, a flexibility activity, a strengthening activity, with the goal of having the person, stick with it for their life.
Mm-hmm.
And I again think that's what's one thing that's amazing about Above and Beyond Cancer is there's so many different options for the participant to, maybe they don't like indoor cycling, but that's okay because they could go try. There's plenty of other things to choose from.
Yes.
And so that's what's so great is they can find what their niche is and what really kind of gets their wheels rolling and gets them excited to be active and move.
Yeah. Have you had much experience using as a physical therapist for individuals undergoing major weight loss? Perhaps shifting a little bit, not necessarily related to cancer, but patients who undergo bariatric surgery, surgical procedures to try to limit the food intake or digestion, or patients on Ozempic or other medications.
Have I ever had experience with that?
Yeah.
No, I have not.
Okay.
But I did just listen to a podcast about the people taking Ozempic or those other medications.
Because I would think it'd be very important to make sure exercise is a component of that lifestyle.
Yeah, but no, I have not.
Okay. We're going to open up for questions, but before we do that, anything about physical therapy and oncology or about exercise and medicine that you wanted to make sure we heard about tonight before we go to the Q&A?
No, I will say, though, as a physical therapist, you can get a referral from your oncologist, but you can also get a referral from your primary care doctor, your orthopedic any doctor or nurse practitioner, PA can send a referral for physical therapy.
Isn't it?
In the state of Iowa, you can come without
you can refer yourself.
Referral. However, your insurance might not always cover the.
So I would imagine as a standard practice, somebody comes referring themselves, you would like to get a doctor to sign off on it just to make sure that the reimbursement happens and the patient doesn't have an unexpected out-of-pocket expense.
Correct.
But technically a patient can refer him or herself for physical therapy.
Yes.
Yep. And do you know the only x-ray that a patient can order on themselves?
I have no idea.
What would you guess?
Stress fracture?
No. It would be a screening mammogram for a woman. They can order it. They do not have to have a physician order it.
Didn't know that.
That and physical therapy, they have it in common. So I have a feeling we're going to have lots of questions.
Sure.
So, and we might even have people coming up and say, it hurts right here. How can I I've got this low back pain. So, okay, here's one comment. What would I think 75% of people over the age of 65 experience low back pain at some point in time. How do you, as a physical therapist, approach low back pain?
Well, it's a matter of determining the structural cause, whether that's muscular, joint, nerve involvement, right? The sciatica down the leg. And then going from there as far as treating what specifically is causing it, helping the person get stronger, stretching, etc.
But do you do that assessment, or do you rely on, okay, well, they just saw their doctor and their doctor says it's this? Do you just run with that, or do you do your own assessment?
Sometimes the doctor might write that they just have low back pain, which is what the person will also tell me. So sometimes when they come, they'll have a specific back pain diagnosis.
But they just might write the diagnosis as low back pain. And so then you need to, first of all, do a bit of a assessment so that you can make a determination of what you think the source of the back pain is.
Based on their what they're telling me, as well as in the tests and measures that you would take them through.
Okay. And what sort of tests and measures would you take them through?
Like range of motion of their back, their hips, then neural testing as far as if they're having pain down a leg, those kind of things.
And then if you determine that there seems to be pain in the distribution of the sciatic nerve, what is the types of interventions that you would use?
And then determining where along the course of it, it's, being restricted, and then treating that.
And within the course of 1 hour, you would make it some sort of determination that you think that sciatic nerve is being compressed, either at the spine or in the piriformis or the lateral, based on your experience and the physical examination findings and the symptoms.
Right. And hopefully they'll leave feeling a little bit better than they came in, even though you have them do all the bending, lifting, twisting.
And what's generally their page of homework?
I try to limit it.
Okay.
14 years ago, I tried to give them the litany, and that doesn't work.
Okay, so what would be
number
one?
To think
the
that
number one thing for them to do at home
years.
For low back pain?
Oh, well, it just depends on what they got going on. I hate to say it.
Yeah, it's sort of this general low back pain that's kind of with sciatica along with it, but nothing else.
Specific stretches?
Something that you think they will do that will make them better.
Yeah, and hopefully feel better. And I like to limit it to 3 within the first
I'm just
day.
asking for 1. You can give me 3.
Okay.
But I want you to give me at least 1 very specific.
Are you going to go home and do these stretches?
I might try it.
Are you going to be a compliant patient?
I don't know. You got to call it an exercise, not a stretch.
Oh. Is that like the journaling of the symptoms versus the diary versus the
log? If you gave me an assignment, but if you told me to go stretch, I'm much more likely to do an assignment.
Well, this could be an interesting psychology.
It could, but I'm just wanting 1 assignment.
Well, a piriformis stretch. Oh, sorry. A piriformis homework assignment.
And what would that look like?
Would be more of crossing your leg over the other one, sitting up as tall as you possibly can, and then if need be, you could lean forward.
Okay. I kind of need help getting and then leaning forward,
but sitting up.
Are we done with this exercise yet?
Yeah.
Okay. And how long do I hold it?
I would try and hold it for a good 30 seconds, which is kind of a long time.
Okay. And then is it important to be bilaterally symmetrical with the
always
exercise?
To not be lopsided.
So you always get 2 exercises out of the 1.
Right.
Okay, great. I think we're going to open up for questions while I do the other side.
Okay.
So questions for Esmie Holderman, Doctor of Physical Therapy.
You said you have training in aqua,
Yeah.
the pool. So we have 3 pools here. We have a 94 degree is 93, 94, 84 degree lap pool and a hot tub. So someone with lymphedema and neuropathy, is there some exercise you would recommend, and would you even recommend the hot tub?
Well, I probably wouldn't start in the hot tub because there's lots of great exercises you can do in the pool itself. So the pool has some really great benefits of the water itself, with providing an amount of pressure on the limb to help with the edema that the person might experience. So in and of itself, the water can be therapeutic for that. The neuropathy, just moving is going to be so helpful for the neuropathy. So if you find, or anybody else finds, that weightless environment to be easier to move in, to get that blood flow, movement, and oxygen to those nerves, that is what they love, then that's excellent. The heat and the hot tub always throws an interesting component to it, because then you have other factors like blood pressure, etc. Being in the hot tub can be another issue. But yes, any and all movement in the water can be great.
Does it matter temperature?
Well, I think that's for
the
personal
temperature.
comfort.
Okay.
If someone has more arthritis, then a warmer water pool can be much more comfortable. But if the person doesn't have a problem, exercising in a cooler pool, then that's just as effective.
Okay.
You briefly touched on vertigo,
Oh, yeah.
and is that something that you routinely address?
I do not
or can
routinely
do?
treat that. We have someone at our clinic who does.
Someone in the clinic?
And there's various causes of vertigo. We touched on the BPPV, but there's other things that cause people to be dizzy that can be
And the BPPV
benign
is benign
paroxysmal positional vertigo.
Okay, and that's the one where we think
The crystals.
that the crystals get stuck.
Dislodged.
Now, aren't there like special chairs that are made to go through those motions?
I don't know.
They kind of rotate and go back and.
Well, yeah, usually you just turn and
Gotcha.
then
So
lay
you
the
used to
person back
Okay.
on the mat
Okay.
with their head in the correct position, and then rotate and have them go through the whole thing.
Okay.
Just maybe another question. You mentioned about blood restriction,
Oh.
and I've never really heard about that. It sounds contrary to what we always think. You're supposed to have good blood
Right.
flow to your
So
muscle.
it's meant to be as a tool to help increase the strength. So the theory is that by decreasing the blood flow, having the person do a strengthening activity. So the simplest example is, right, like a bicep curl. So if you put the cuff on further up the arm, right above the bicep, have the blow it up, it constricts the arm. You have the person go through the curls with the less blood flow, so it's really taxing on the muscle, and so that basically more strenuous activity based on the lack of blood flow really helps build up the muscle. which can be helpful. So if someone isn't as active, I talked about the MS, the person who has MS, so they might not be as active, and then they can participate in it and get some great strength benefits if they can't, go through a million repetitions. Or then the high level athlete who maybe, can't be doing squats or lunges can stay in their fitness level by participating in these type of strengthening exercises within their weight bearing status that they're trying to follow, for example.
Other questions for Esmie? We have one over here.
A comment question from a viewer. Christine says, it's kind of and she's got a couple of comments here. She says, 3 abdominal surgeries with colon cancer, chemo, and radiation. Last surgery was ileostomy reversal, something February, but still have times that it feels like a pulled muscle in the groin area, also across the belly button. Would this be helped with physical therapy? Or could a trainer help, which might be a question in and of itself, the difference between physical therapy and a physical trainer?
So someone who's had multiple colon surgeries and sounds like had a colostomy or ileostomy, had that reversed. And so you've got abdominal scars. And
But
it sounds
also
like
there's been a lot of trauma, a lot of the integrity of the abdominal wall is not as it used to be.
Yes.
And so that's where I would say physical therapy might be more ideal than a personal trainer, which PT is both, right? Personal trainer, PT, physical therapist. But I would say in this case, the physical therapist might be better, at least to start with, to take the person through some specific abdominal strengthening exercises, making sure there's no hip involvement as well. If they say their groin also is uncomfortable. The one thing that we didn't talk about is pelvic floor therapy after different kind of cancers.
We've actually had the pelvic floor physical therapist on that maybe touched base with that. Individuals that have had pelvic surgery or pelvic radiation have some particular issues related to the pelvic floor that could include in a woman the vagina, the bladder, the rectum, and that surgery and radiation therapy can cause considerable scarring and dysfunction. So we have specially certified physical therapists that work on the pelvic floor. It might even include, on a woman involving intravaginal types of physical therapy.
Yes. But we didn't talk about that.
Do you want to talk about that or anything?
I have no experience with that.
Okay.
But I think I don't think a lot of people know about it.
Right. No, I'm glad you brought it
There
up.
are also males who might experience some issues after prostate or colon cancer, where I think oftentimes pelvic floor, they're thought of as for females, but it is not gender specific.
Right. So men who've gone through prostate surgery might have loss of control of their urine, loss of the ability to get erections, changes in bowel habits, and all of those require muscular activity that happens down in the pelvis. Okay.
So
another question.
Just a question about my own experience with physical therapy. I've been a couple of times. I'm always surprised at how low impact the physical therapy is. I kind of pride myself in being, a high intensity athlete. And when I go to physical therapy, I'm almost wondering whether or not it does any good because it's so low impact. So talk about the fact, I guess, that physical therapy can work being low impact, or is it a case where the physical therapist is just being overly cautious, I think, not wanting to do any harm? So what they're doing is very low impact. It seems to me like anyway, but if you could talk about that.
Well, they might be meeting you specifically where you are. So if you're the very eager patient, sometimes they might feel like they have to take it maybe down a little bit. Or being an overzealous person, or sometimes the person might be opposite. So trying to encourage them might be necessary. But that is the goal of physical therapy, is to provide you with specific exercises for your specific impairments that you have come to have addressed, that you would need to work on, if that makes sense. So it's not going to be some, rigorous, activity. It might be targeted at specific muscle strengthening assessments, assignments that you would need, or stretches.
And I imagine it would depend also, is this this is after a major surgery where you may need to ease into things because you don't want to cause problems with the healing, or is this right after an injury
where they
a
have
torn
pain.
muscle or something?
Mhm.
I remember after a shoulder reconstructive, the first session with physical therapy was, we're going to lift your arm up over your head. And I just remember, you could do. So that was like the physical therapy of the day, was just to see if we could get the arm
moving.
up. Good question. We have time for one more question. We're almost out of time. One more question.
Might have one from on.
How about a hip replacement question?
Here's a comment from a viewer, Doc.
Okay, we don't get to do the hip replacement.
Oh.
This is the last question. Here we go.
This is regarding the value of Tai Chi and doing aquatics for restorative health. I mean, can you restore health with aquatics, and then do you prescribe or work with people as far as Tai Chi is concerned?
Well, Tai Chi would be a great community-based exercise that someone can participate in afterwards, that has great strength and balance, as well as breathing and mindfulness components to it.
Mm-hmm. And fall prevention. It's evidence-based program to reduce the risk of falls.
So that would be a case of, that would be a nice thing for someone to maybe take up or continue with or resume once they're done with their.
And water aerobics, my experience, it tends to be people are wanting to get back into it. It gives there's some comfort of being in warm water. There's the support you get from the water, and can be a good way to ease back into an exercise program.
Yes, but water is not for everybody. Some people are petrified of water, and some people are petrified of putting a bathing suit on. So it's not for everyone.
Thank you.
I can say that from experience as working in the pool for 5+ years.
Okay. Well, Esmie Holderman, Doctor of Physical Therapy at the MercyOne Riverside Rehabilitation and the MercyOne Richard Deming Cancer Center. Thanks for being our guest tonight.
Thank you.
If anyone knows someone that would benefit by watching this program will be available on demand at the Above and Beyond Cancer YouTube channel or the MercyOne Cancer Center website. I hope you'll join us again next week for our cancer education series. Thanks, everyone.